in jail. And but to make a long story short, these were the first cases of the pandemic that we're discussing. The Chinese put their best scientists on the problem, and within a matter of weeks, they'd identified the cause of these pneumonias was a new coronavirus that they termed SARS coronavirus 2. This virus, next slide. Next. This virus went on to cause a huge outbreak in Wuhan, China, which is a province in central China. It's a large industrial city. And next slide. The virus needed a name. And the virus was very, very similar to a virus that had been seen about 15 to 20 years earlier, called the SARS virus, the systemic acute respiratory distress syndrome virus that caused severe pneumonia, and had been seen in Hong Kong and Singapore and in China. It was just slightly different, so they called it SARS coronavirus 2. And that eponym has stuck since that time. Next slide. Well, it didn't take very long for Wuhan to have a huge outbreak. The Chinese government reported they'd had 3,000 cases. There's very good evidence they probably had 10 times that many. Every hospital in this city of 10 to 20 million was filled to the brim. They had people waiting, people were dying in large numbers. The mortuaries were totally full of victims of this outbreak. But they controlled the outbreak by very, very stringent measures. They basically sent everybody home and said, you don't leave. Everybody was in lockdown, home quarantine. And that controlled the pandemic, the epidemic in Wuhan. However, they did not shut down the 40 or 50 flights a day from the rest of the world that came in and out of Wuhan. And within less than 2 weeks, there were cases of this virus causing pneumonia in the United States and in Europe. It spread that rapidly. And as you can see, within weeks, there was a huge global pandemic was established. It tells you how rapidly a new pathogen, particularly an airborne pathogen, can spread in the era of modern transportation. Remember, in an average year in the world, 1 billion people get on an airplane and fly domestically or internationally. So the world's gotten very, very small, and the capacity for spread of new diseases is increased enormously. Next slide. The pandemic hit the United States first in New York City. And in New York City, they got hit very, very hard. And they had many, many thousands of cases. Every hospital in the city was full, every ICU was full. And so many people were dying that the mortuaries could not handle all the bodies. And they parked these refrigerated trucks next to the hospitals. Some of the hospitals had as many as 20 or 30 refrigerated trucks. Each one would hold up to 40 or 50 bodies and keep them in refrigeration till they could be processed by a mortuary. It was a huge pandemic. The mortality of patients with COVID-19 pneumonia in ICUs in New York City in the first 6 months of the pandemic was 80%. It was 80% for a variety of reasons. In part, they didn't know how to take care of these patients. They were overwhelmed. They were very short of staff. And the consequence was a devastating high mortality outbreak. Next slide. Well, there's good news because as we can see, if we look at when it started back in January of 20, we had huge numbers of deaths due to COVID in the United States. These are all United States data. These are deaths. And this was actually the worst And in January, February, and early March of 2022, we were overwhelmed. All of our ICUs were full. And as I said, in 6 ICUs that I cover, we had about 55 beds, and 50 or 51 of them were COVID patients. And all of them except for one had rejected the vaccine. Only one person on a ventilator there had the vaccine. And it tells you the impact of the vaccine. Good news, we see that the number of deaths has declined markedly. In fact, it's declined so much that a lot of people say, well, we don't need to worry about COVID anymore. We don't need precautions. We don't need vaccine. It's not a big deal. It's just another influenza. Well, as I'm going to show you, it's not another influenza. About 350 Americans die every day due to COVID. Now, that's New York Times statistics this morning. It's not gone away, and it's still a very serious problem, and it's killing a lot of people. Next slide. This is a summary of worldwide US and Wisconsin data as of several days ago. There have been almost a billion reported cases in the world. The true number is probably 3 to 4 times higher, easily. United States, where we probably had more cases diagnosed for the population because we have a healthcare system that has the resources to do a lot of diagnostic testing. We've had 100 million documented cases in a population of 300 million people, and this is about half of the true number of cases. Because there have been numerous cases that have been diagnosed with home testing, they never get reported. And so the true number, we estimate that 60 to 70% of all American citizens today have had COVID. We've had 1 million people who've died from COVID. And in Wisconsin, we've had 2 million cases out of about a population of 5 to 6 million people. And we've had the lowest mortality, much lower than the global or the US mortality. Next slide. I'd like to spend a little time talking about the uniqueness of the virus that caused this outbreak, because it truly is unique. And it's so unique, it's like a science fiction novel. Next slide. This is an electron micrograph of the virus, and this is enlarged several million times. And you can see these little projections on the outside of the virus. Next slide. This is a schematic of it, and lets you see these little spikes make a crown, and corona in Latin is crown. This is a crown virus. And these are the mechanism by which the virus attaches. It attaches in a very sophisticated fashion. When it gets to a cell, little projection pull out automatically, and they pull the virus right up to the surface of the cell so that the virus can empty its DNA or RNA into the cell. Now, let me tell you what a virus is. Viruses are different than bacteria. Bacteria that cause urinary tract infections, boils, pneumonia, gastroenteritis, are free living, independent living, unicellular forms, and amoeba is really, they're called germs, but they have complex metabolism. They absorb nutrients from their environment. They reproduce. They can do this totally independently. They don't need anything else to live. The fundamental algorithm of life is that the DNA in the cell governs everything that happens in that cell. The DNA is the brains of a cell. All cells have DNA in it. And the DNA has genes that trigger the synthesis of structural proteins that make up the cell and functional proteins such as enzymes that catalyze all of the metabolic events that allow that cell to be alive and live and to reproduce. A virus is very different than a bacterium. A virus is nothing but a packet of DNA or RNA that's surrounded by a protein coat. There's no enzymes. This virus sitting in the environment is totally inert. In fact, there's a tremendous debate whether viruses are alive or not. Do they fulfill criteria for life? They can do nothing in the environment. But once it gets to a cell that it's able to infect, it injects its DNA or RNA into the cell and totally takes over the cell. It turns off the DNA of the cell and it controls all of the metabolic machine in the cell to do nothing but make more virus. It might make 1,000 copies of the virus in that cell, and then the cell breaks open. All these virions are released, the cell's dead, and each virus goes on looking for another cell to infect. And viruses are very, very common in nature. There are millions and millions of viruses. All species have their own virus. There are snake viruses, insect viruses, human viruses, goat viruses. And these viruses usually are very selective. Human viruses don't infect dogs or cats or other species. And insect viruses do not infect humans or mammals. This virus, as you're going to see, is very different. Next slide. First of all, coronaviruses are not new. We've known of coronaviruses for 75 years. Most of the coronaviruses in nature infect animals or animal coronaviruses. Next slide. They cause pneumonia or diarrhea in food animals. In humans, we've known about 4 endemic strains of coronavirus that cause colds and occasionally pneumonia. They're just not a big deal. And this virus is very different from any other coronavirus. Next slide. Why should we have been surprised by COVID-19? Because we really had been warned. It's really sort of shameful that we were warned amply and we never prepared. Next slide. This is the 3rd coronavirus pandemic of the 20th century. Next slide. Next slide. In 2002 and 2003 in China, a bat virus adapted to infect humans and mammals and caused an outbreak of pneumonia that affected about 1,000 people, and it killed 11% of them. That's a very high mortality for an infection. And it was a very scary virus. It mostly infected healthcare workers. They got it, and many of them died. And it was a devastating outbreak, particularly in China, Singapore, Hong Kong, and Canada had several hundred cases. Why we didn't have an outbreak is mysterious. For unknown reasons, after about 10 months, the virus disappeared and it's never come back. Thank God. In 2012, in China again, another bat coronavirus emerged called the Middle East Respiratory Syndrome virus. And this virus had a propensity to infect camels, and it caused a lot of disease in the Middle East. It spread through multiple countries in the Middle East, but it also caused disease in China and Korea. And it had a 34% mortality. That's very scary. But it was not very contagious. And over the course of the last 10 years, there have only been several hundred cases, and it's not been a big deal because it's not very infectious. When this virus appeared, it was another bat virus, and this virus has the capacity of being highly, highly infectious, and it spread around the world. Next slide. Is this science fiction? Is it an alien virus? We know it's a bat virus because there's a big institute in Wuhan, China, that studies coronaviruses. They've been studying coronaviruses for the last 20 years. And they particularly were doing a lot of experiments on bat coronaviruses. And all three of these viruses are bat viruses that were adapted to be able to infect many other species, including humans. So this is a bat virus that made the jump to humans. Next slide. This virus is unique in so many ways. One that's right off the bat is that most viruses have a very selective tropism. They only infect one species. Dog viruses only infect dogs. They don't infect cats or humans or other species. This virus infects virtually all mammals. In fact, a quarter of the deer of Wisconsin have been infected by this virus. And it infects dogs, cats, all kinds of species. And it's a problem because they may well be a reservoir for maintaining the virus in the population and allowing it to change its structure and become more virulent. Next slide. It's associated with almost universal viremia. Very uncommon for viruses to cause viremia. There are a few viruses that do, such as cytomegalovirus, but very few viruses do. There's no other respiratory virus, and there's about 20 well-known respiratory viruses. None of the others causes viremia. Next slide. That means virus circulates and lives in the blood. Next slide. Most viruses, most human viruses, only infect one or two organs. Respiratory viruses, the flu virus only infects the respiratory tract, doesn't infect any other part of the body, never in the blood, never in the gastrointestinal tract. And gastrointestinal viruses don't infect the respiratory tract or other tissues. This virus infects literally every organ in the body. It infects the lung and the respiratory tract, but it also infects the heart, the GI tract, the reproductive organs, the skin, and the brain. So it's not choosy at all. Next slide. It has a capacity for prolonged intracellular persistence. It can disappear from the respiratory tract, but it can go into a latent stage of infection within cells that's only been discovered in the last year or so in trying to understand the cause of long COVID. And there's a lot of suspicion that long COVID, people who are sick for months and months after the initial infection, may be related to persistent intracellular infection. Next slide. It's a uniquely virulent respiratory virus. There's never been a respiratory virus that's been more virulent other than its sister virus, the Meyer's virus. Next slide. It causes an unprecedented amount of inflammation, and the inflammation is what makes people sick and die, and we'll talk about that shortly. Next slide. Post-infectious natural immunity doesn't last very long. It's pretty much gone by 6 months to a year, and reinfection is very common. Next slide. It's extraordinarily contagious, and it's transmissible person to person, primarily by the airborne route. An airborne route means it can be suspended in the air, can survive in the air, and it can spread huge distance air. You can go through the ventilation system and infect people in rooms 200 feet away. Next slide. And it causes active infection year-round. No other respiratory virus causes infection year-round. We never see flu in the summer. We never see adenovirus in the summer. Never. We see COVID all year round. Next slide. And it has the capacity of producing prolonged post-infectious symptomatology. We call that long COVID. We'll talk about that. Next slide. Lastly, it's got a very high rate of spontaneous mutation. It when it multiplies in cells, it makes mistakes when it encodes for new virus. And there might be 10 different strains of coronavirus that come out of one cell. And these little mistakes, most of the viruses don't survive. They've had something happen to their RNA code that is not commensurate with them being able to survive. But by sheer numbers, when you're looking at quintillions of virions, you're going to select out some that have a mutation that's beneficial, that makes it more infectious, or it's more virulent. It can survive in the air much longer. And when that one appears, it will become predominant. And we call these new strains variants. And these variants can enhance infectivity, and there's great concern they can enhance virulence. Next slide. There have been over 300,000 genetic linkages identified already to date. It's probably closer to 500,000 now. Next slide. We started with alpha and beta in early 2000, and then in late 2000, and then for almost a year, the Delta strain, which was much more, made people sick, quite sick, and it was much more contagious, dominated. Next slide. And then in 2021, late 2021, the Omicron variant appeared. Everybody's heard about Omicron. That was a gift from God. The Omicron variant is much less virulent than the variants that preceded it. And as you can see, it became the dominant strain. Next slide. Now, Omicron is being supplanted by lineages. They're descendants of Omicron. BBX 1.5 is becoming dominant. Again, these strains are just not very virulent. Next slide. You're much less likely to be hospitalized or need ICU care, and you're about 10% likely to die as compared, say, with Delta. Next slide. Next slide. People get sick with COVID because of the inflammation it produces. It doesn't nibble away at our vital structures. It triggers our body to self-destruct because it triggers our body to pour out a huge amount of inflammation. And we're literally being consumed by the flames of our own immune inflammatory response because it's such an excessive response. And that's characteristic of this virus. It's like Ebola virus in that way. Next slide. It also is prothrombotic. It triggers a lot of clotting. It makes you much more likely to clot. Clotting is heart attacks. Clotting is strokes. Clotting is a cold leg where a surgeon has to open it up. And clotting, nothing is good about clotting that isn't there to stop bleeding. Next slide. And it causes disproportionate inflammation of the lung where we get hypoxemic, which is low oxygen related respiratory failure. Our oxygen levels drop very low. And we struggle to oxygenate people to keep their oxygen levels at a level that's commensurate with survival. Next slide. You can see in the lungs become filled with inflammatory fluid, and severe COVID pneumonia is the major cause of death due to COVID. Next slide. There's a high risk of secondary multi-organ injury. We see kidney failure in patients sick enough to go on a ventilator in an ICU. About a quarter to a third of them will have kidney injury, and half of them will need to be dialyzed, at least temporarily. So that inflammation has a big negative impact. It affects the heart, the kidneys. It's a big deal. Next slide. We look at the mortality. A lot of people, when COVID came along, they said, why are we getting all excited about it? I see congressmen, I didn't know congressmen were trained in medicine, but congressmen saying this is just flu. Why are we getting all bent out of shape? The mortality of COVID right at the beginning was about 25 times higher than garden variety influenza. Much, much higher. Next slide. age was a big risk factor. The older you got when you got COVID, over 80 had a 15% mortality in the first 2 years of COVID. 15%. Next slide. Individuals who have pre-existent morbidities such as heart disease, diabetes, high blood pressure, COPD or emphysema or cancer were much more likely to not survive COVID. Next slide. It was thought initially, CDC and WHO insisted it was spread by droplet nuclei. You see all these little tiny droplets of saliva when somebody coughs or sneezes. They don't go very far. They go about 2 feet and they drop to the floor. But if you're in the radius of this person, they cough, you inhale these, and that's a very efficient way of spreading. That's the way flu spreads. Flu does not spread long distances. That's respiratory transmission. And next slide. It seemed very obvious to us that there was other modes of transmission than droplet nuclei or contact. Next slide. I thought it was absolutely overwhelmingly likely that respiratory transmission occurred with COVID-19. And I wrote a paper that I sent to the CDC, I sent it to the New England Journal of Medicine. There was controversy over this, sent it to the New York Times. Nobody would publish it. And I was infuriated because it was very important for WHO and CDC to acknowledge respiratory transmission occurs because preventive measures are based on our understanding of epidemiology. And if you didn't think, if you didn't believe it was transmitted by a respiratory route, then you'd say there's not a problem in nursing homes. Well, what happened in nursing homes? Thousands, tens of thousands, hundreds of thousands of deaths in nursing homes because they don't have capacity for respiratory isolation. A friend of mine works and has a large infectious disease group in New Jersey. He took care of patients. His group took care of patients in a nursing home of 500 people. They had 90% of the patients died of COVID in that nursing home, 90%. Next slide. Next slide. Here was just some of the evidence. This is a big ship called the Diamond Prince. And in early February of 2020, it went out on cruise, and then a patient got sick with COVID. So they stopped in Tokyo to get the patient off to a hospital, but they wouldn't let them take the crew. They wouldn't let them discharge any of their passengers. So the ship simply sailed around Japan for a couple of weeks, trying to decide what to do. They put all the passengers in quarantine. You stayed in your room. You never left your room. They brought the food to the outside of your room. And finally, after about 2 to 3 weeks, they let them disembark in Japan. By that time, they had 700 patients who had COVID. And most of them never seen each other. They'd been in quarantine for that entire, it went through the air system. And they were able to isolate virus from the ducts of the air system. Next slide. So that's a very important issue for control. Finally, in July of 2020, a bunch of people who were interested in public health wrote a public letter in the New York Times saying, WHO and CDC have to accept that this is airborne. And they grudgingly did. Next slide. Next slide. The symptoms of COVID-19, if you get it, are very much like flu. You're generally going to have some fever. It may only be low grade. You're very likely going to cough. You may feel short of breath, even though your oxygen levels are normal. And you may be achy. You may have congestion. That's very, very common. When I had COVID with my wife in August of 2022, the congestion was profound, absolutely profound. And the coughing was just racking. I thought I had whooping cough initially. And, but it's almost impossible to discern on symptoms from flu. Next slide. This is the sequence of events. You're exposed. By day 3, you can diagnose it with a PCR test of a nasal swab. By day 5, you're coughing, you have congestion, you're symptomatic. And if you're unlucky, it's going to progress. You're going to get pneumonia. By day 10, you're very short of breath. Your oxygen levels are low. You're going to get hospitalized a day or two. And another day, you're going to be in ICU on a ventilator. Next slide. This is a CT scan. This is a almost normal CT scan. Air is black. And this is the person's laying on their back. This is the heart. And these are the lungs that you see. They took a very thin slice through this section of the lung. All of this is tremendous inflammation. This is severe COVID pneumonia. And it's very, very characteristic. Next slide. Testing by PCR has been one of the most important weapons we had to control COVID. Unfortunately, the CDC refused to allow FDA to approve diagnostic tests. 20 companies at least brought in tests that they developed for diagnosing COVID. How are you going to treat people with COVID? How are you going to prevent spread if you can't test for infection? And there was no commercial test available. CDC planned to market their test and control that was the only logical reason why they would not approve the others. Finally, it was so embarrassing, CDC's test wasn't working. And they finally had to approve it. The companies stepped up and they got testing kits out very, very quickly. And within a matter of weeks, a huge amount of testing was being done. But the bottom line was we were in the midst of a huge pandemic. Our pandemic took off in late February and early March, and we were off to the races. Next slide.
What year was that?
It started in 2020.
The testing.
2020. We're in the 3rd year of the pandemic. So the testing, there's 2 types of testing. Everybody's heard of polymerase chain reaction. This is the gold standard. It's a very good test, very accurate, very sensitive. Rapid tests that you can buy commercially that were distributed by the government, the antigen test, they give you a rapid result, but they miss about 20% of the cases. That's their problem. And if it's negative, but you're very suspicious, say you've had an exposure, you're symptomatic, repeat the test in another day. Next slide. This is what's coming. This is a very clever test developed in Finland, where you breathe into this machine, it detects molecules that are released in the infected patients, and they're able to, it looks like it's as accurate as PCR. It's not yet on the market, but it's a very promising technology. It's been well evaluated. Next slide. Next slide. Individuals who have underlying disease are much more likely to do poorly. Next slide. So what happens if you got a positive test? And you may call up your physician. I tested myself, I'm positive. The first question your physician is going to ask is, do you need to be hospitalized? And if you're at high risk of doing poorly by advanced age, you've got heart disease, you've got cancer, you've got severe COPD, you're on home oxygen to begin with, you'll probably be admitted. If your blood oxygen level is low, you'll definitely be admitted. Certainly if you have radiographic evidence of pneumonia, or if you've got an altered mental status, you will be admitted without question. What if you don't have any of these? You don't feel great, but it's like a bad case of flu. Your oxygen levels are fine, and you stay home. You stay in mandatory quarantine for a minimum of 5 days, better 7 to 10 days. And you monitor your blood oxygen levels. You can buy this in Walgreens for about $40. It tells you exactly what your oxygen level is. And your healthcare system will be in touch with you by telephone, and they may even send out a nurse to check on you if there's any question. And most people can be taken care of at home if they're not at risk and they're doing okay. Next slide. However, what we will do, people at high risk, we want to do something to prevent it from progressing and making them sick. Next slide. This has changed the ballgame. We used to have back one. Okay. We used to have monoclonal antibodies that were developed in the test tube that targeted the virus. And they were very effective. They greatly reduced the risk of people going on to be sick if they were given within the first 3 to 5 days. These don't work anymore. There have been so many variants that the antibodies do not match up. So monoclonal antibodies are not available. Next slide. But the good news is 2 new drugs, and particularly one, Paxlovid. This is an old AIDS drug that really never made it for AIDS, but they took it out and they tested it and it looked terrific. And they did studies and it showed if you give this to somebody at high risk person, older, comorbidities, and they get this drug started within 3 to 4 days after the onset of symptoms, it reduces the likelihood they'll be hospitalized or die 90%. This has changed the ballgame. This is now widely available. You should have no trouble getting this if you're at risk. If you're low risk, you're younger, you're healthy, you can get the drug, but it's not going to have any impact. It doesn't seem to change anything. But it's very valuable for high-risk individuals. Next slide. What if you need to be hospitalized? Next slide. We're going to isolate you in a high-efficiency filtered unit. Next slide. And we're going to anticoagulate you so that you stop forming clots. You probably are starting to form clots already by the time you're hospitalized if you're sick. Next slide. And anticoagulation reduces mortality, clearly has a mortality benefit. Next slide. Next slide. If you need oxygen, we're going to give you anti-inflammatories. And this is the first drug that had a really big effect on COVID for sick people. Next slide. This is a large WHO study where they looked at various treatments for people who are sick with COVID. It was done in tens of thousands of people. And what they showed, this simple, cheap steroid, dexamethasone, in a relatively modest dose, if it was given to people who needed oxygen, they're on a ventilator, it was very clearly beneficial. On a ventilator, it reduced mortality almost 40%. It really made a big difference. And on the other hand, if they didn't need oxygen, it actually increased mortality because it reduced your immune system to fight off the virus. So we only give this to people who have evidence of inflammation-induced hypoxemic respiratory failure. Next slide. We now have additional anti-inflammatory drugs that also reduce mortality further, called the JAK inhibitors. This is a powerful anti-inflammatory drug, and we're now using these drugs widely. If people have severe hypoxemic respiratory failure, they further reduce mortality. We can do so much more for severe COVID in the ICU than we could only 2 or 3 years ago. Next slide. And we can even put you on a heart-lung machine for patients who we think have a chance of surviving, we simply can't get their oxygen levels into an acceptable range. We can put them on a heart-lung. It's an artificial lung, an artificial heart, and it oxygenates their body for them until they heal. We've had people on ECMO for 40 or 50 days, and they walked out of the hospital, they survived. Next slide. People got very excited about hydroxychloroquine early in the pandemic, in great measure because the president at the time was very pro hydroxychloroquine. When there was no data whatsoever, no studies, and people clamored for it. You couldn't buy it, you couldn't get it anywhere. People were buying them from veterinary outlets, horse hydroxychloroquine and horse ivermectin. And when this got studied in good trials, randomized trials, there wasn't the slightest evidence that brought any good. In fact, people who got hydroxychloroquine were a little more likely to die if they had severe disease. Next slide. The drug ivermectin, which is a wonderful anti-parasitic drug, won a Nobel Prize for the development of this drug for treatment of helminthic infection, which is worms and parasites. It's got in vitro activity against the virus, but on the other hand, the amount you have to give to kill the virus is far more than a human could tolerate. And yet people wanted ivermectin, and this got pushed very hard. And in a very sad personal note, one of my colleagues got convinced ivermectin was the word for treatment of COVID, even though the data there was just no data at all, and insisted so much that he basically was terminated at the university. It was heartbreaking. Next slide, there have been numerous studies of ivermectin, and they just don't show that it does anything. And yet people are clamoring to get it. There are still physicians who prescribe it, and it has no evidence that it's beneficial. You know, people say, well, you're hiding it from us. It really works. You're hiding it. Why would we hide it? If something's going to help a patient, for heaven's sake, I would love to give it to them if it works. But if it's not going to work, why would I give it? Next slide. Next slide. I'm going to just go through these ones fast. Just next slide. A little bit about control with masks. One thing I want to tell you, and that is cloth masks are placebo masks. Cloth masks are cosmetic masks. They have no filtration capacity, just virtually none. If you've got 6 or 8 layers, you have some, but most of these don't have that. The best mask you can get is an N95 mask. They've been studied very, very well. And this is N95. We've been using those for tuberculosis for the last 30 or 35 years. And this is a KN95 mask. We have universal mask at the hospital. This has got the same filtration capacity as an N95, but it's very comfortable. You can wear it all day if you need to. And if you're going to wear a mask, it doesn't make sense to me to not wear a mask that is effective. If you're going to wear a mask, you want a mask that works. Don't rely on a cloth cosmetic mask because it's no different than placebo. Next slide. We do universal masking in the hospital. We use face shields for all contact with patients. Next slide. And in the community, home quarantine, the population, we had a shutdown, and the shutdown clearly reduced spread, but it was at a great price, as we'll talk about shortly. Next slide. When I went to Singapore about 10 years ago to consult on healthcare for their Ministry of Health, I went in January, flu season, and I was shocked. Everybody in the country had a mask on. They had a good quality mask on. All the masks in the hospital, they screen you when you got to the hospital. They did temperature screening with infrared devices. And if you look like you might have a fever, they pulled you aside, they tested you and sent you home. And everybody who worked in the hospital got tested every other day, and everybody had universal masking. They had very good data. This stopped the spread of SARS 10 years earlier, and they've been doing that for flu now for probably 20, 25 years. Next slide. Masking has been shown to clearly reduce spread if it's done consistently with good quality masks. That's the crucial thing. Next slide. What about vaccines? Well, there's many types of vaccines you can get. You can take the virus and kill the virus in the test tube and then grind it up and inject dead virus to stimulate antibody production. You can take the virus and you can put the RNA into a vector, a benign virus, a cold virus that infects you. It introduces the virus to your body, stimulates an immune response against it. You can take the nucleic acid, the messenger RNA of the virus, inject that, and your body cells will pick it up and use that RNA to make antibody against the virus and stimulate an immune response. When COVID broke, within several months, 75 universities and companies publicly announced that they were developing vaccines. 75. And the good news was it was a wild success. Next slide. I call it a medical Manhattan project, like World War II in developing the nuclear bomb, which they did in 3 years from scratch. Here, this was far better. They started in January and February when they knew they were going to have an outbreak of a new pathogenic coronavirus. And within 9 months, they had a messenger RNA vaccine that stimulated very good immune response. They did studies in hundreds of thousands of patients, big studies, never less than 40,000 subjects. And they tested, did you get infected or not? Did it protect you from getting infected? And by December of 2020, these vaccines were approved for release. That's less than a year. That's unbelievable. Normally, developing a new vaccine takes somewhere in the range of 10 to 15 years. And this shows you how effective it is. Here, they give the vaccine here at time 0. And these are the people who get placebo here. And you can see this is the cumulative rate of infection. It goes up and up and up and up and up. You take the people who got the real vaccine, by 14 days, they stop having new infections. It was very, very effective. It was highly effective. Next slide. This vaccine was far more effective than most of the other vaccines that have been developed. But the ones developed by Pfizer and Moderna in the United States were clearly the most effective vaccines. There's about a dozen different vaccines that are available around the world. Next slide. And they weren't expensive. That's a very inexpensive vaccine. Next slide. One thing they discovered once they started immunizing widely, by about a year, they started seeing breakthrough infections, saying we need to give boosters. And after a year of the initial vaccine campaign, they started giving boosters. Next slide. And the single adverse effect of the vaccine was allergy. And the risk of this was about 1 per 125,000 recipients. And nobody died in the first 76 million doses of vaccine given. Most of these people were sent home after they were treated for their allergic reaction. And many of them tolerated a second dose of the vaccine. Next slide. At this time, only 40% of the country, about 60% have received at least one dose of the vaccine. That means 40% haven't, and that's really unfortunate. Next slide. It was argued, our congressmen experts were going around claiming natural infection was far better than vaccine immunity. And when it got looked at very clearly, it turned out that vaccine immunity was 5 times more potent and had far better protection in the 6 months after getting the vaccine as opposed to those who had natural infection. The vaccine is better immunity than natural infection. The best of all is having had the vaccine and having had infection. It's called hybrid immunity. Those people have probably superb immunity for life. Next slide. That's me. Next slide. Next slide. These are the data I showed you, a number of cases. Next slide. There's other issues. This is something a lot of people aren't aware of. This is a study done in 73,000 veterans in the VA administration. And what they showed, if you compare what is the likelihood of having a cardiac, an acute coronary event, a heart attack, or an arrhythmia, or heart failure, or a pulmonary embolus, or becoming diabetic. And if you had symptomatic COVID and were hospitalized, and you survived and went home, you were about 2 times more likely to have one of those events in the year to follow. So COVID primes you for bad things. A good reason to want to protect yourself from getting COVID. Next slide. This is particularly true with cardiac problems. Next slide. The economic impact of the COVID pandemic was profound. I mean, we spent $10 trillion trying to control COVID with the stimulus packages and everything, added $10 trillion to the national debt. It's probably more than that now. And our inflation now is the highest it's been in 40 years. Next slide. Next slide. It really beat up the healthcare system. Many healthcare workers, particularly nurses, ultimately quit. They said, I can't handle this anymore. And we have serious shortages of good nurses. Next slide. Long COVID. What's long COVID? Next slide. This is the persistence of incapacitating symptoms months after the acute infection is long gone. Fever's gone, the cough is gone, everything. But next slide. You're very fatigued. You can't get out of bed. You're short of breath. You have chest pain. You're coughing a lot yet. Your joints may hurt. You can't sleep. You can't concentrate. You can't work. You're very depressed. This is a real thing. And it's seen in up to 25–30% of patients who have severe symptomatic COVID. Next slide. And it's associated with a 2 times increased risk of having a heart attack, hypertension, atrial fibrillation, heart failure. It's a big deal. Next slide. What is causing long COVID? Well, it's likely one or both of these: persistent inflammation and viral persistence. Next slide. Here's a study in Australia. It's a beautiful study. They compared people who had COVID but had no long COVID. And then they compared them with people who had long COVID after COVID. And they measured levels of inflammatory molecules. And as you can see, they're much higher in the people with long COVID. These people clearly have persistent, uncontrolled systemic inflammation that's probably driving this. And a study from NIH recently showed they could detect the virus in the cells of half to 2/3 of these people. Next slide. It was devastating for public education, particularly early elementary school kids lost a year. It had a profound negative impact on education of American children. Next slide. The country became very polarized over the vaccine and masking mandates, which I think is tragic. Next slide. So what does the future hold? We've made a lot of progress in treating critically ill COVID patients. So why has the mortality dropped so markedly? That's a question I would think everybody has in the back of their mind. Well, first of all, we do a lot better job treating critically ill COVID-19 patients, but that is not enough. That would not account for what we're seeing. Even though we're saving the majority of them, it's not going to have that much of an impact. The vaccines certainly have a big impact. They probably saved 1 million lives alone, just the vaccines. Over half the population now has had COVID-19 and they've survived. And these people have some partial immunity, so they can get COVID again, but they're much less likely to get real sick or have to be hospitalized or die. But I think a very important thing is what I talked about, the Lord's gift to us, Omicron lineage. The evolution of new variants has had a very typical pattern, selecting strains that are more infectious, but they are clearly less virulent. And Omicron, for all the people who rejected the vaccine, God said, here's Omicron, you'll take the vaccine whether you like it or not. I'm giving it to you naturally. Next slide. So what are we going to face? 1918, nobody knew what to expect when 50 million people died around the world. It was a little blip a year later, then it disappeared, never to come back. Thank God. Next slide. On the other hand, SARS did the same thing. We don't know why. Next slide. However, the Middle Eastern respiratory syndrome smolders on, smolders on. Next slide. So what do we need? We need to better ways to overcome vaccine hesitancy and the rejection of a safe and highly effective vaccine. Next slide. We need new vaccines that incorporate the most recent strains. Our vaccines are already a year old. Those strains are gone. They still have some benefit, clearly, but we need to give a new bivalent vaccine now that incorporates the current strains to have maximal protection. And the government's been very slow about that, and that's been very frustrating. Next slide. We need far better support of CDC and state health departments. They really got beat up badly during the pandemic. Next slide. We need a rapid, more sensitive, and a more accurate home test. I think that'll come. Next slide. We need exclusion of public health agencies from intrusive political interference, of which there was tons early in the pandemic, and a profoundly negative impact in controlling the pandemic, and it divided the country, unfortunately. Next slide. We need far better pandemic preparation. The next pandemic could come tomorrow. You heard of monkeypox? A year ago, the world missed a bullet. Monkeypox appeared, it spread globally, but we were lucky. It was not highly contagious. And it was almost only exclusively in gay men. There was very little of it in heterosexuals, very little of it in children, and we were lucky. If it had been a highly contagious virus, it would have had a huge negative impact. We would have had a new pandemic. Next slide. Winston Churchill, this is a rephrasing of Lord Chesterton's famous saying, those who fail to learn from history are doomed to repeat it. And that's so true when we're talking about pandemic preparation. Thank you very much. I apologize for talking too long. Be happy to try and take a few questions. Yes.
Dennis, thank you very much. I did see you talk about, well, at least have in some of the slides, the impact on the brain. And being part of NAMI, the National Alliance on Mental Illness, I did see over maybe a year and a half ago that people with schizophrenia, and I can't quote the studies that were done, but those people seem to be more prone to the COVID than others, and especially if they're older and more prone to death. And I didn't know whether
That's true. That's true for development. Children with developmental delay are very vulnerable to COVID and don't do well. It's the same thing.
Thank you.
You're right.
Do you think we'll be getting a yearly vaccine now or something
Yes,
like that?
I'm just disappointed that the only reason we got the first bivalent vaccine about a year ago was because the companies did the testing on their own. They had no guarantee. They spent huge amounts of money to develop them and test them and show that it works, so that when the government finally came around and said, I guess we'll release it, then they had vaccine to give. But the sad thing is the new bivalent vaccine has been only received by about 18% of the population. And that's very unfortunate, because the vaccine holds the greatest hope for protecting vulnerable people.
My question is about your special mask. Tell us again describe it and where can we get it? The one in your pocket. Your mask.
Gail and I get our masks online.
Okay.
We get them at Amazon,
Okay.
and they're called KN95 masks.
Yeah, that we have.
And they're comfortable, and they've got a good filtration, but they've been tested well by FDA.
So,
And you can buy a packet of them. They cost less than $1 each, and they're usually good for 4 or 5 days.
Yeah, the slide with the different vaccine companies, the slides went through pretty quickly. It looked to me like Moderna and Pfizer were very comparable statistic wise effectiveness, and J&J was kind of further down, correct? And in the future, is it advisable? Because late, the recent ones, oh, you can switch, it doesn't matter, but is it advisable to stick with the same one you've had?
The studies have shown you can mix the vaccines for boosters. There's no adverse effect. In other words, if you started with Moderna in the primary series and you get a Pfizer for a booster, it's just as good if you'd gotten a Moderna. I personally prefer Moderna only because you get higher antibody levels, but I've taken Pfizer because they didn't have any Moderna several times.
After you've had COVID and you're at increased risk for inflammatory problems in your body for 6 months or a year, you were saying that a blood test to determine inflammatory markers might be
Oh,
helpful?
we use a whole variety of blood tests for measuring inflammatory markers,
Yeah.
and the research has been done. Also, tests for markers we don't test for clinically, but they expand our understanding of the response of inflammation. And most people who have severe COVID, they're positive on all the inflammatory markers. They're whoppingly positive. They're positive at a level we normally never see with any other disease. I'm sorry? With moderate illness with COVID, the markers parallel the clinical severity of the disease. So if you have severe disease, you're in an ICU, your markers are often off the scale. And if you're in a general ward bed, you're mildly sick, but you're not on death's door, your markers will be elevated, but they won't be markedly elevated as a rule.
Doctor, what is the long-term implications for mental? I have some friends of mine who have what they call COVID smell or taste because they had COVID and now what they used to taste isn't the same, or what they smell isn't the same anymore. So I was wondering if there's something that happens inside COVID with regard to the brain and how it registers and people react to it.
Well, COVID clearly can affect the brain. There's no question about it. And if we do spinal taps on people with COVID who are real sick, we often see cells. When you see cells in spinal fluid, it's been a marker for inflammation for 300 years. When the first you don't normally see any cells in spinal fluid. And people with COVID often have cells. They have ongoing inflammation.
Question from online. Is it safe to fly?
I actually had a set of slides there, but I left them out. The airlines have done a very good job in that they've tremendously beefed up their air handling systems. They filter the air now with a high quality filter. They have many more exchanges per hour. But still, nonetheless, I would not fly without a mask. Wouldn't dream of flying without a mask. I take my N95 mask and would tape the edges and to prevent any leakage around the edge, because you're sitting for 2, 3, 4 hours and with a large group of people in very close proximity. There aren't many things you can have that close to proximity. The remarkable thing is we haven't had that many large outbreaks on planes, but it's a tribute to what the industry has done in terms of their air handling. So that's helped.
Thanks, everybody. We're on 10:25, so I know some people want to get upstairs. Dr. Maki, thank you so much. And next week, Elise Uphoff is going to talk about her seminary experience. So I hope you come back.
That represents Christmas.